time you have any questions or comments related to the content, we can stop and discuss it. This is not a lecture style. What I have been asked to talk to you about is our core measures and how we're doing within our perioperative services service line. This is something that is getting more and more attention as it's now available as public data. You can Google hospitalcompare.gov or go directly to that website, and you can see the data for any hospital which receives CMS funding. Their data must be reported and is on this website. So you can compare Memorial Hermann with St. Luke's, with Methodist, with anyone in town, anyone in the nation. So we really want to make sure that the data we're presenting to the public is quality data and also that it's accurate data. Why do we have to skip and hop? What are all these acronyms? Why are they important to us? Because Dr. Katz said so, and also because it's best practice. Dr. Larson and Dr. Daly are our anesthesia champions, and Dea, our clinical director, is the nursing champion. So that's why it's especially important for our departments, also as we're key components of all surgical operations. What this is National Quality Partnership of organizations focused on improving surgical care and reducing complications. What that equals to is lowering our morbidity and our mortality for our surgical cases. Who came up with this? Why do we have to follow this? Who came up with it? These are the people. This is the group that got together on the national stage and figured this out. What is going to be best practice? What does the literature say? Where are our opportunities for improvement and for standardizing guidelines that will fit small hospitals, large hospitals alike, so that those smaller facilities that are not large academic centers like ourselves, who don't have the research capabilities, don't have the academic sponsorship to spend time doing research, can still be practicing quality care, evidence-based practice. We see AORN, who is very important to our practice here, the CDC, Joint Commission, Veterans Affairs, and most of these physician organizations with the surgeons, anesthesiologists. So many of these are dedicated to quality improvement that affects us and how we care for our patients. Who is skip and hop? Although we are only measuring a certain population, a lot of this really applies to all of our patients. And so a question that I have for you is, beta blockers. A patient comes in on a beta blocker. What does that mean about their surgical care? It means that under skip protocol and under general research that we know through reading our nursing journals, that patients who are on beta blockers, who have coronary artery disease or having vascular procedures, they need to receive a beta blocker in the perioperative period in order to lower their risk of morbidity and mortality while on the table and in the immediate postoperative period. That's something that we can do. That's a red flag for us. How can we make sure that everyone knows that? So this is our 18 and over, no clinical trials, length of stay less than 120 days. Our people who are living here, it's not applying to them. Our people who come in with MRSA, VRE that is known, we're not talking about them. We're not talking about burns, major traumas, or people who are having serial washouts or serial surgeries. But that does not mean that these same standards of care don't apply to them. It just means we're not auditing those charts for national data display. This should not change the way you practice. For y'all, all of your cases are being audited. All your cabs, all your vascular. That's a huge population, and it's a lot on y'all, which makes you a great example of exemplary practice because you're already doing this, your numbers are fantastic. Now if we can just get the rest of the hospital to follow through. If you can do it, then surely they can as well. Because like in the other
holding, they don't even ask that question.
Right. And it's a very important question, and that's something that we're going to be pushing, and it's part of the reasons why they've got me going around talking to everyone. Over in the main areas, hips and knees, hysterectomies, whether they're open or laparoscopic, colon cases.
I don't say anything.
So, just because they may not be audited, we want to make sure that we're still following them. Here are some of the things. Antibiotics. We have the grid. There's the grid that they can follow and look at. We can encourage surgeons to that grid. We can pull it up, we can find it, we can give it to them. We can look at it ourselves and say, you've ordered vancomycin, were you sure to document the rationale why? You know, and you can always just put it off. Say, you know, it's really important for the CMS reimbursement that all of this is documented in the chart, because we know they want to get paid. I know I want to continue to keep my position here. I think it's important that we help and work as a team on these projects. down here at the surgery stop time, that's going to be changing to the anesthesia stop time, that they discontinue antibiotics 24 hours from the anesthesia stop time rather than the surgery stop time. So that will be a change that's coming up, and feel free to begin looking forward to that. Other things that are being measured, these would be our glucose, which is very important for y'all, hair removal, which they're doing in the OR, and normothermia post-operatively. That's something that has got to start in the OR. Obtaining normothermia cannot be done rapidly within 15 minutes. It's just not safe. If the patient comes out very cold, obviously do all of the appropriate rewarming procedures, and also just remind that anesthesia that was in the room how important it is to begin that process towards the end of the case to really help for the patient's best outcome. Hair removal, we're excellent about this. Sometimes on pre-op, patients will say, oh, well, I'm going to shave at home. Remind them, if they want to do that, to use clippers, not to use the razor, and let them know that we're happy to shave them here, that is not a problem at all. We're happy to do that. And then post-operative glucose, good luck. The beta blockers, this is our biggest fallout. I did an informal audit yesterday. I had a sample of 41 charts. There was only 20% compliance on the beta blockers. Very frightening. Everything else looks pretty good, but this is something that we really need to follow through with. The home medication records, asking them multiple times, asking the family members, we really have to catch all of these. What a sad excuse for someone to be at an increased risk for cardiovascular compromise because we didn't follow through. I don't want that on me, and I know you don't want it on your conscience either. Patients, VTE prophylaxis, TED hose, SCDs, let's just order them. Continue to follow your anesthesia record, looking for your stop times, your drug listings, things that may be written in here, such as beta blocker not given due to hypotension or bradycardia. We really want them to provide numbers. Hypotension, systolic 90s. You know, a number is really helpful. Or beta blocker given preoperatively. Beta blocker given in post-anesthesia care unit. That's fine too. It has to be given, as far as the research says, 24 hours prior to surgery or before they leave PACU. Between that range, which includes at home, morning of, pre-op, intra-op, and post-op. There's a lot of opportunities there to catch them to help reduce their risk, but I think because it's so broad, people keep pushing it off. And we need to make sure that it gets done. And you're the last stop here. Thank you for your time and patience. I really appreciate it. Are there any questions?
No.
Thank you so much. And good luck in continuing our core measure efforts.
We'll be 100%